Good afternoon, everybody, from a very wet and soggy Cardiff. Hope you can hear me and you can see the screen clearly. I'm going to talk about zones and cones, two of my favourite topics at the moment. So we'll initially talk about zonal fixation because I think it's an important topic to base revision research on, and then we'll look at how the trabecular tibial and femoral cones fit into my practice. At the end, I'll take any questions and I'll hopefully give you as honest an answer as I possibly can on anything you're in here to query. So zonal fixation is a concept we've had for a few years now, and we look at three zones: the epiphysis, or the joint surface, the metaphysis, and the diaphysis. What we're trying to do is look for multi-zone fixation. So when you're doing the revision, you want 2 up to 3 zones to look for you. Today we'll go through all this in brief, but we'll concentrate on zone 2 metaphyseal fixation through the piece on cones. It's important to get good fixation because if you don't in revisions, it's going to fail. Here's a great example, one that I always show, where there's been a good revision, it's a good implant, but poor fixation. Zone 1, there's a little bit of cement. Zone 2, there's nothing, or again, a little bit of cement. Zone 3, the stems are too small or too narrow. So in all 3 zones, we failed with fixation. That's inevitably going to lead to loosening and failure, and we can do better. So zone 1, the epiphysis, the surface cut, we want to establish a stable surface with flat aligned cuts. And then any defects you can think about augmenting, reconstructing cement, bone grafts, or metal. Fixation in zone 1 is always going to be cement with current implants. Zone 3, the diaphysis, in my book, it's all about bone quality. And whether you go fully uncemented or cemented, it both works. It depends on the implant, the bone quality, and what sort of fixation you want and why. Zone 2, though, is something we've historically just bypassed. But using metaphyseal surface to reconstruct defects with sleeves or bone grafts, cement or cones, gives us a good zone into which we can get fixation. Fixation zone 2 will only be through sleeves or through cement. It's just a matter of how you reconstruct to get your fixation. Here's an example from Exeter from Andy Thomas, who's a good colleague, and I pay him every time I use this slide. And he's taken this bone defect problem, reconstructed with impaction bone graft and mesh, and ended up with zone 1 cement fixation, zone 2 cement fixation, and zone 3 supported uncemented stem. Fixation is reliant on good reconstruction. These were my own cases: elderly female, poorly balanced primary knee, too much constraint leading to early polyethylene wear, osteolysis, and we can see massive bone destruction in the femur and the tibia, and almost complete loss of the lateral cortex due to polywear. So when you reconstruct, we've got to think about what zones we have left and what we're going to use. In my hands, this was a sleeve in zone 2, a little bit of cement in zone 1, but because of the uncontained defect, I've got a large stem in it. And it works. You know, you get good fixation. That uncontained defect will slowly reconstruct. And you can see here, a year out from surgery, where we've got good bone regeneration. To get this, I've had to go for a very long stem. And long insulated stems have issues. This patient did well apart from some stem tip pain. So maybe these days I do it a little bit differently. That's where cones come in. And again, cones, they're not a new idea. We've had them for almost as long as we had sleeves. And the idea is that you're going to get reconstruction in zone 2 to enable you to get cement fixation. So the cone is reconstruction, the fixation is cement. And what you should be trying to do with the cone is get your fixation reconstruction closer to the joint line. And with that, you can then get a slightly shorter stem fixation, and you haven't got to transgress too far down the femur or the tibia. Let me give you some examples. This is a multi-revised infected knee with several attempts at extensive reconstruction, all of which had failed and infection had come back. So I opted on a two-stage process here. Static spacer, thinking this might be definitive surgery. Patient, however, despite the infection clearing and being mobile, did not like a stiff leg. So we talked about reconstruction. Here I've got problems with fixation and reconstruction above and below the joint. And so we've gone for reconstruction using triple metal cone in the femur and the tibia. I've gone for shorter stem fixation because I can fix in a good zone 2 and zone 3. It's now after about 5 years. Extensors still weak, still an issue, but we elected not to reconstruct that because of the soft tissue envelope I had to deal with. So TM cones, been around a long time. They give you an option for reconstruction, but they haven't evolved. It's static for many years now, and it's time for something new. And that's where these trabecular cones come in. They're designed for modern implantation, reconstruction, and fixation. I'll talk you through the advantages that I see with these trabecular cones, how I use them in my practice. And there has been quite a bit of evolution. The cones are designed to have a sealed inner wall so that you're not going to get cement egress out into the uncemented peripheral fixation. You've got a porous outer wall for bone ingrowth, and you've got this compressor which allows AP and ML elasticity, giving you hoop stresses for initial fixation and to allow bone ingrowth. The compressor means you can really impact very firmly without the risk of fracture. Use hoop stresses to enhance your press fit, and because you've got a constant interface tension, I think that promotes bone ingrowth. Trabecular itself has a three-dimensional structure with predictable pore size and porosity. It's made of a titanium alloy, again good for bony ingrowth. Also slightly helpful if you're dealing with infected cases. There's an antibacterial effect of the titanium alloy. When would I use it? If we just look at Allison classification, type 1, 2, and 3. For type 1, generally you wouldn't need a cone for reconstruction, except that is in possibly elderly osteopenic bone, where the zone 2 bone is very soft. And then you might find that just putting a cone in zone 2 allows very predictable fixation with cement. I wouldn't do it in all cases, but certainly the elderly, I would consider it. Zone 2 almost always needs augmentation, centrally or peripherally. Cone is a very good option here. Then zone 3 with major uncontained defects, when your fixation is compromised from the outset. Establishing a good fixation in zone 2 using the cone is always a good option. Again, I'll give you some examples. Here's a case I was sent, hinged and cemented sleeve case, but the joint line is in the wrong place. So the joint is proximalized and anterioralized. So we've got a patella baja secondary to a bar joint line. This patient couldn't extend because the joint line was out of position. Had pain as walking on a bent knee. This is a well-fixed implant, but for the patient, fully functioning implant. When you explant a well-fixed scleral like this, you're going to get bone loss. So you have to have a means to reconstruct. And here we chose a tibial cone in the tibia with shorter cemented stem. The femur, you can see we didn't put a cone in, but we've managed to push it backwards, so my posterior joint line is where it should be. The anterior joint line is pushed backwards, and the joint line is really where it should be. Let's compare. So we're pushed distally, we're pushed posteriorly. The bar has now gone because the joint line has been reconstructed. I'm pleased to say it's a very, very easy technique. Our rule of thumb using cones, trabecular metal cones, and now trabecular link cones, is that I basically just choose a size that will fit in the defect. There are some tabs to break down any harder edges, but really just find a size that drops into the defect and you won't go far wrong. Little plastic trials you can use along with your trial implants. You can explant them easily, and then you have a little introducer that allows you to get a press fit where as you do that, you'll see that compressor at the front just closing up. You know then you've got those hoop stresses, good interface tension. Another case, stem tip pain. Really well fixed tibial sleeve, stem tip pain. Despite modifying her activity, giving her pain relief, she wasn't coping, so we elected to revise. We went again to a cone, a much shorter stem, and cemented stem fixation. And this worked well for her. It's a big operation, re-revising well-fixed, uncemented implants. You need to think ahead about reconstruction options. Right, a little bit of bias here. I tend to use full cones. And when I was using TM cones, it would be a full cone. Now trabecular cones, it's a full cone. Almost never, well, I actually don't use these at all. And the reason being, most of the defects you'll see are medial. Most of the good bone stock is lateral. So this is where you want your maximum bone coverage. Lateral, posterior, and where you can anterior. So putting the least amount of bone contact here doesn't make sense to me. This is where you want your bone ingrowth laterally and posteriorly. So going for a hemi-cone just doesn't make sense to me. That's my bias. Here again, I would go for these boys, just the biggest cones you can get in. Don't go for these ones, and these ones just make no sense to me whatsoever, apart from pushing up the share price of link, which of itself is not a bad idea. However, if you want good fixation, go for your full cones. And these boys will work with any of the link prosthesis that you want to implant, up to including distal femurs, where you can put these cones into the mouth of the open femur and produce a secondary zone of fixation, as well as your cemented stem. So far, we talked about femoral tibial cones. Femoral cones have only recently come to the market at the start of this year, and so I've got limited experience, but I will share my experience with you. Here's a case, the last ones I did with tibial cones only. Infected, multi-revised, and cemented fixation. One stage. Here I've gone for tibial cone, tibia, and the femur, because I just don't want stem fixation only here. So I've gone for a cone above and below. It's a single stage, hence there's lots of stimulant for local antibiotic delivery, and good antibiotic cement above and below. He's out there about 18 months at the moment and doing well. Getting this secondary zone of fixation in the femur and the tibia helps your longevity of fixation. Another case, old implant I put in many years ago, about 12, 13 years ago. Not great fixation because I've got nothing in zone 2, got a big stem doing all the work. Inevitably it loosens, and the same in the femur. Cases I did historically, just not working in the long term. So here, we've gone for cones above and below, we've gone for tibial cones above and below, because that's all I had available to me. It worked in conjunction with good cemented stems. There's always a but. If I'm putting a tibia in a femur, it's not designed for the purpose. It helps. In this case, although she did well, produced a fracture, because where the cone is short in length, where you go from zone 2 to zone 3, you get a sharp corner, get a little stress riser, and I produced a fracture. Didn't affect my fixation, got a cemented stem, good contact all the way around. But it's disappointing when your x-rays look like that. So you need a femoral cone designed for the femur. These have become available at the start of this year. This is what they look like. And they do give you a good option in the femur. I was lucky enough to be involved in the trialing of these on cadavers, and these are synthetic x-rays we took in Hamburg at a wet lab I did with Thorsten Dirke. And one of the problems with a CAD lab is you have a certain size of bone and a certain size of femur. They don't always match. So this femur is just ever so slightly smaller than you need for this size cone. What we ended up doing was, you can't quite see it, but we fractured this little area here. And this is the point where I realized these cones do give you a good option, because despite the fracture goes up and along here, those cones were really well fixed. And I believe that's because we have these compressors allowing very tight interface tension with fixation. And also we're going from zone 2 into zone 3. So we're bridging the zones. We're reconstructing and fixing across zone 2 to zone 3, getting longer zones of fixation. If you compare femoral zone to a tibial, femoral cone to a tibial cone, you can see the difference in length. Fixing zone 2 to 3, 2.5 fixation, if you will. So as I said, they come in January, just before lockdown. So I've done a couple of cases, and this is the very first case. Again, really well fixed femoral tibial sleeve. The joint is the wrong place. Painful fixed flexion deformity. Not a problem of fixation, a problem of function. This blade couldn't extend, so we opted to explant and reconstruct. When I explanted, yes, I managed to fracture both condyles. This is me hammering a little bit too hard. Because I've got a cone now that bridges zone 2 to 3, we had good on-table fixation. On post-op, we can go for immediate full weight bearing. Standard tibial cone below, femoral cone above. Gets you out of all sorts of trouble. Again, look at that fixation zone. It's akin to a sleeve. It's longer, it's three-dimensional reconstruction fixation. It's length 3 doesn't matter. Now this is the last femoral cone I used. This is a bit of a salvage case. Infected, loose megaprosthesis in the tibia. You can see loose all the way around here. It's infected. I have no hope of getting rid of the infection, but I do hope to get rid of the pain from a loose stem. So about 3 or 4 weeks back, we went in and did a big one stage on the tibia. Lots of anti-loaded cement, and I pushed a cone down into the interface. And I've got the compressor in there. I've got a good bony interface, and I'll be able to cement through to hopefully give me at least a little bit of fixation to relieve pain. I have no expectation this will give me a long period of fixation, but for the moment it's doing the job. I'm happy to criticize this. The trabecular cones, I think they're an advance of what was there before. We've got good inner wall that doesn't allow egress of cement outwards. We've got an outer wall that's porous and designed for a press fit. We've got this spring-loaded compressor to give you interface tension to good press fit initially and good bone growth in the bottom. What else is new? Just mention quickly the OptiStem. This is the link version of a stem on sleeve in combination. This was initially designed as a custom-made implant to give you zone 2-3 bridging with a very long fluted mega stem that's close to the joint and gives you fixation in large femoral cavities. I first came across it in this custom-made case. It's not mine. One of my colleagues showed me the X-ray. It's now available off the shelf if it's necessary. No personal experience, but this will give you fixation. I'd hate to expand it, but it'll definitely do. And then when you talk about custom-made implants, if you take a sleeve and you extrapolate it for custom-made megaprosthesis, then you can come up with this sort of design where you can bridge almost any type of defect. It's custom-made for the tibia. Again, I have no experience with these, but they will give you reconstruction options that standard cones won't. Cement through this and get good fixation. So to conclude, my experience with tibial cones now is growing quite a bit. Femoral cones, I'm still on a learning curve, but they do fill a gap, and they do allow you to get reconstruction fixation going from zone 2 to 3 in femoral anatomy that you haven't been able to do before. These stems give you an immediate press fit with stability on table. The elasticity of the compressor allows the AP and ML axis to bend in and give you predictable compression. And because it's a cone, you can cement through almost any of the endomodel family with it. And should you choose to do so, you can pretty much use any implant you want to. It doesn't have to be an endolink. You didn't hear me say that. So zone 2 reconstruction is important. It aids fixation. Trabecular cones are, I believe, in advance, almost out there historically. instrumentation is better, the compression is better, reduced risk of fracture, increased fixation. When you're doing complex revision, you need to have options. I still do uncemented fixation where it's appropriate, but increasingly in the re-revisions, having this cone option really does help the sort of cases I have to deal with. I can recommend them to you without any hesitation. With that little bit of marketing and sales to you, I'll take any questions. Thank you. Sean, over to you, mate.
Yep, thank you very much, Rhidian. So please encourage everyone to type your questions into either the chat bar or into the question bar on the right-hand side of your screen there, and we will work our way through and answer as many as possible. But I'm going to kick off while people have a think, Rhidian, by asking you the question. I've heard you mention before that you would use some shorter stems because you're putting the cone in there. It's avoiding you have to use as long a stem as you normally would. Is that a claim that you would be comfortable to make widely and something you would recommend? Would you comfortably tell people to use considerably shorter stems, and where do you draw the lines on that?
Yeah, look, I come from an uncemented philosophy, and I still use uncemented implants. But it's an evolution in my knowledge is learning how to use stems. And when I first started using cones, I used to go for a much longer stem because that's what I always used to do. There's been some really good work from the Edinburgh School looking at, I think, probably striker implants and striker cones. They've done the analysis and it really doesn't make a difference. As long as you reconstruct zone 2, you can shorten that stem. And that does make a difference in terms of the input you have to use. And also, unfortunately, you do revisions, you're going to get failures for infection, failures for soft tissue reasons. So knowing that you haven't fixed the whole of the tibia, the whole of the femur, does allow you a bit of confidence so you can go back in and revise for whatever reason. And if your fixation is not going to be significantly improved having a really long stem, why do it? Sometimes you have to. And certainly if you're doing salvage procedures, megaprosthesis, you're fixing very differently. But if it's a first time, second time revision, why fix longer than you need to? As long as you're into zone 3, you haven't got to use the whole of zone 3.
Thank you for that. We've got a question here. Would there be an indication where you would not recommend the use of a cone? Obviously, failing, of course, if we've entirely lost the proximal tibia, it may be hard to put one in. But would there be other indications where you would not use cones?
Yeah, look, use whatever fixation you've got. If you've got good bone stock, if it's a revision of a primary where really it's an easy explant, it's a small central defect, you don't need it. If the bone is there, the bone will allow you to fix into. Think of a cone as reconstruction. I would use it often in osteopenic bone if I think fixation is going to be poor. I'm going to use them in re-revisions where zone 2 is already compromised. But you don't have to use it all the time. Definitely reconstruction, poor bone quality, not all the time. You know, yeah, I think use a bit of common sense. And much as I love making money for Link, they're doing okay, guys. You haven't got to put in everything.
We didn't ask you to say that. Going to scrub that section out of your contract.
Okay.
The question here asking, what do you see would be any specific advantages of a cone compared to a sleeve? And I guess I can augment that question by saying, what influenced you in changing your practice, and when would you potentially still look at sleeves as the #1 option?
So sleeves I still use. I have a mixed practice. I think it's been an evolution for me as a surgeon, from going from a pretty much fully uncemented sleeve surgeon for an initial part of my career, during which I learned a lot about how to revise. Fortunately, my practice involves a lot of re-revisions, a lot of very major bone defects, and it is hard to get good uncemented fixation in those cases unless you go for a very long stem, and you then get uncemented fixation at diaphysis longer and longer. You get stem tip pain. Your fixation is not as predictable, because if you're relying purely on uncemented stem, it is hard if your bone quality is poor. So for me, I get a lot of re-revisions, so I want to have the option. I might use a sleeve, I might use just a standard implant, but if you've taken out an uncemented implant and with it you've had a peripatetic fracture, it happens. You've lost a lot of metaphyseal bone stock. There's already a bone defect. You've got to think about reconstruction as well as fixation. And for me, I need to think about 2 zones. and I can get zone 2, sorry, on zone 3 pretty much all the time. But if I haven't got zone 2, zone 3 works harder. And if you're doing distal femurs, proximal tibias, I think cemented fixation has an advantage. Then I want to get a pseudo zone 2, so I'm putting cones into the open mouth of the femur, proximal tibia, distal tibia, whenever I can to augment my fixation. My practice is a little bit skewed. I use both, but I'm lucky because I'll try and develop a strategy that allows uncemented and cemented fixation, as long as it's good fixation.
Yeah, for sure. Thank you. Okay, next up we have, for this links closely to the last question, for proximal tibial uncontained defects, what would be your limit for cone use?
Yeah. So the difference is, are you going to go for proximal tibia or are you going to reconstruct? Proximal tibias are essential in cases, you know, and so you need to be prepared to do that. If you've got 3/4 of the fixation, so you've got say a lateral wall, posterior wall, anterior wall, then you probably reconstruct with a cone. If you're down to 50 to 60% reconstruction, then your stem has to work harder, and your cone might give you an additive effect as an augment, but it's not it doesn't really go from uncontained to contained. And then you need to start thinking about proximal tibias, distal femurs, making that zone 3 stem longer to work harder for you. If you can reconstruct and be certain that reconstruction is going to really work, then you can go for that shorter stem we talked about earlier. But you need to look at the case in front of you and have confidence whatever you choose, reconstruction with a cone, with a sleeve, proximal tibia, cemented stem, uncemented stem, is going to work for that individual.
Yeah, okay, thank you. Would the cones be useful in trauma settings? And this is augmented by saying with massive bone loss. I think you've covered with that last answer the massive bone loss, but in a trauma setting?
I mean, I've tended to go uncemented in trauma cases because of the biological situation. I think it's a little bit different if you do distal femurs for distal femoral fractures in the elderly. But historically, I've got uncemented. These days, certainly in the elderly, I tend to go more cemented, distal femurs in particular. And if you're cutting off a distal femur, why not put an augment into that distal femoral resection to make sure that poor bone quality is augmented circumferentially.
Yeah, thank you. Do you find that if the tibial metaphysis is very sclerotic, that the cone will still integrate, or do you need to combine it with bone impaction?
Okay, so I'm just going to be biased here and say I never bone graft. I showed that one for extra because I just love the pictures, and I say I have to. Andy Toms needs a bit extra money these days, so I slip with 10 every time I use that slide. So look, my background with uncemented fixation sleeves, we never bone grafted those, and if you get good press fit, the bone will regenerate. The same is true, I think, if you put a cone in there. Even though you're cementing through it and below it, if you get a good press fit, interface tension with that compressor, you're going to get bone ingrowth. So I don't bone graft anything, and I've never regretted that.
Okay, thank you. We're being asked, how many surgeries have you performed with cones, even roughly to date? Do you have an idea?
So with the tibial cones, I'm in about 20, 25. Tibial femoral cones, only 2 or 3. 4 if you include the cadaveric one. Just as I started using them, lockdown happened, so my practice at the moment is on hold. But I put a lot of tibial cones in femurs that I probably shouldn't have, but you know, they've worked. I don't put in everybody. I'm trying to be selective. I'm lucky in my practice that I don't have to use one implant for everything, because I think that's quite dangerous. You know, there are certain implants that are better for certain problems and certain patients. And you need to hold up a little bit in your management and say, do you know what, this would far better be an uncemented because a young, big adult, or, you know, we need a cone reconstruction because it's an elderly, poor bone quality patient. So plan the case, and if you can, choose the implant that'll give you the best fixation for the problem you're facing.
Thank you. In a primary severe osteoporotic knee, would you use cones, or do you use cones?
Yeah, I'd have no hesitation. No hesitation. You know, if you push your finger in and the bone just collapses, you need augmentation. Certainly, I find this oddly more in the younger, slightly younger female patient, the obese patient. They just have really poor bone quality, and they may not have been investigated for osteoporosis, but they're definitely osteopenic. That metabolic effect of the obese is a real issue. So if you're going to heavily load poor quality bone, I would have a low threshold.
So the first half of this question I think we have covered, and that is when would you go for a distal femoral replacement and when would you still use a cone? But the second part of it is, do you see indications for tibial or femoral augments?
So I'll go back to the first one. So whenever I can, my philosophy is to reconstruct, purely on the basis that if you have a vascular biological envelope around metalwork, I think it's a little bit protective against infection. If you bring a distal femur proximal tibia, your infection rates are higher. We just know that. So if you can reconstruct, I would, but you got to be sensible. Sometimes you got to do the easy thing, and a distal femur proximal tibia is a straightforward procedure, or should be. Sorry, what was the second part?
And the second part is, do you see indications to still use tibial or femoral augments?
So going back to my experience using sleeves, I went 15 years without using a single tibial augment, and I still think that's the case. So I don't do tibial augments at all. I reconstruct and then I fix with cement, or use a sleeve and stem, no augments. The femur's different. The femur, you want wherever you can to get rotational control. So if you're not using a femoral cone, sorry, if you're not using a trabecular link femoral cone, then you do need to think about augmentation posteriorly to get some sort of rotational control. One of the advantages of the femoral trabecular cones is they have an anterior shelf. The cone's here, the shelf is here. And what happens, your femoral condyle sits on top of that, so you've got rotational interface control. Designed specifically for that, to give you a bit of rotational control. So the femoral sleeve itself will give you it. So again, augments slightly less necessary. Link in Hamburg have developed a cone, an augment system that they haven't historically had. So I think you'll find, I think it's meant to be end of this year, but lockdown may have pushed it back a little bit, that the new cones, the new augments in the femur will become available. They may obviate the need for cones if you've got minimal bone stock loss. If you've got big bone stock loss, put a femoral cone, sit your condyle on top of it, that will give you rotational control.
Thank you. This question here said, you mentioned about titanium potentially having some antibacterial properties. Could you elaborate on that?
Yeah, look, this is a little controversial because a lot of this work started with trabecular metal, and that was industry driven. It was a claim that Zimmer Biomed wants to make. And to be fair, in the lab, trabecular metal does have some properties. The same work's been done by Link on their alloy, and again, it is even more antibacterial than TM is. I wouldn't put it in and claim it's an antibacterial implant, but biofilm finds it a little bit harder to adhere to this implant than others. That's not an advert I'm putting out for this material, but it does have a little bit of antibacterial property. They're the best antibacterial properties, prophylaxis, don't get infected in the first place. But, choose an implant that will give you good fixation, biological ingrowth, plus an anti-adhesive effect, and that will all help you.
On the subject of talking about bacteria, I know a lot of the revisions that you face are obviously heavily infected cases. Do you have any sort of reservations about using implants of this nature in infected cases, or in single stage revisions? Would you always do them in a second stage? Or
I've done both, and for me the implant is less of an issue. I want the best fixation I can get. The hinge is chosen because of instability and soft tissue reasons, so I wouldn't put a hinge in just because it's infected. I know my colleagues in the endoclinic Hamburg, it's an absolute philosophy for them. I just don't adhere to it. I've done plenty of 1 and 2 stage revisions where I put the constraint in based on the soft tissue envelope. If it needs a hinge, it has a hinge, but that's based on ligaments and soft tissue, not because it's infected. So your answer is not the implant itself. It's about, can you clean it? Will the soft tissues allow first 1 stage? Then the implant, the cones, the sleeves are chosen for fixation.
Thank you. Another question for you is, you've mentioned that you've obviously put some tibial cones into the femur and had really good results with that. We're starting to see more and more people are using multiple cones in one side, so they almost have a cone within a cone. What's your thoughts on that? Do you think that's an acceptable practice, something that you've done, would do?
Yeah, I've done it on a couple of occasions in really big salvage cases. Always remember what you get out is what's the salvage option. And if you put cones stacked inside the canal and you get bone ingrowth, those cones are going nowhere. So if you have to revise, you have to be sure you can do a cement and cement revision, which I think is entirely acceptable, and our hip colleagues will tell you that they've got evidence that works. If it's infected, you might be in trouble, and you need to understand if it's all else fails, you're then committed to doing femoral resection above the level of your cones. So you need to be a little bit careful. But if you get good ingrowth, you can do cement and cement revisions, even in infected cases. But, you know, always think ahead and think of the poor guy you referred to for your revision, how much work you're going to give him or me.
I was just going to pass that comment. That's normally you, Rhidian. Everyone's sending them to you.
I'm retiring soon. I've had enough. Sail off to the sunset.
Yeah, exactly.
I wish.
So on the subject of revision, have you taken out many cones throughout your practice, and do you find it is an easy, or as you've alluded to, a difficult thing to do? Any tips for getting them out again?
So I've not taken out any trabecular link cones yet. I will. It's a matter of time. It just is. So cases I do, I'm going to get failures. I'm going to have to do re-revisions. I have taken out TM cones, and they are incredibly difficult because you do get bony ingrowth. Where TM cones are different to trabecular cones is that you can destroy them. You can take an osteotome and you can shatter them. You won't be able to do that with the trabecular cones because of the construct. So the reverse gear here is slightly different. This is why I think you need to be comfortable doing cement and cement revisions for a TM cone in. Unless it's loose, don't even bother to revise it because you won't. TM cones slightly different. I've taken lots of those out. It's just a technique issue. So there's a whole lecture I gave on how to do it without destroying too much bone. Same with sleeves. You know, you saw some of my fractures. That happens, but there are techniques for taking out sleeves with a minimum destruction. So explantation is just a different technique you need to be comfortable with if you start doing re-revisions. These trabecular cones now their own technique attached to them. Haven't crossed that bridge yet, but I will.
We look forward to when that comes. Next question here is, would a tibial tubercle osteotomy compromise cone fixation?
So no is the answer, because I do it all the time. I just have a very low threshold for doing tubercle osteotomies. It helps my explantation, it protects my external mechanism, helps my implantation, my reconstruction, and it makes no difference. Now, if you've got a very major medial defect, and I showed you some x-rays earlier where there's no medial wall, you just don't need the osteotomy to get in and out and help the explant. So in those big defect cases, you don't need the osteotomy. Other cases, you can do it with confidence. But again, tubercle osteotomy is a technique. You have to learn it, and you have to adhere to the principles. Again, that's a whole different lecture. But I had no issues with it, and I have no concerns. And it is actually quite pleasing. You put the trabecular cone in, and then because you've got the hole, you see the compressor compress. It's actually very, very pleasing. The defect is irrelevant.
That's great, thank you. This question is not specifically linked to cones, but at what point do you consider amputation after multiple re-revisions? Does bone stock play a part in that decision?
So I don't do enough amputations. I'll be honest, I got 3 patients circling my practice at the moment, one of which was the case I showed you where I put the femoral cone in the tibia. You know, I can't cure that infection, and eventually I'm going to run a bone stock, and that patient will have to accept an amputation. I've got one case at the moment where I've tried 20 years to keep a leg on, and the patient is going to have an amputation next week because I should have done it 2 years ago. And that's my ego getting in the way of common sense. So yeah, amputations for me, it's uncontrolled infection, skin loss. You can always reconstruct bone defects. You can go to total femurs if you want to. but there has come a point of just common sense. I'm learning that backwards because I can reconstruct an awful lot of things that maybe others wouldn't. But there comes a point where amputation is needed. And I have 3 patients circling my practice, one of which, if you let me, I will amputate next week. So yeah, bone loss, yes. Soft tissues and infection predominantly.
Thank you. This is one of my own questions, maybe a simple one, but do you have any preference, or would you change your preference of bone cement viscosity or anything when you're putting cones in? Would that affect you in any way whatsoever?
We've only got one bone cement in the department, so I have no option. Okay. It doesn't seem to matter.
No, for sure.
There are some cements available. I've used vancomycin and gentamicin loaded premix cement, and that's a really good premix cement. It takes ages to set, and if you're going to put a cone in there, what you don't want is backfill. So you've got to wait a little bit longer with that sort of cement. Standard Palacos type cements, yeah, just wouldn't worry too much about it.
That's great. We have managed to work our way through the questions. I should just ask if anyone has any more questions, if they would please type them in. We shall give you a few minutes to do so. And if anyone has not noticed, on the right-hand side of your screen, you should have access to a handout, which is a download of the femoral and tibial cone surgical technique. So feel free to download that whilst we're chatting. We should just give everyone just 1 or 2 minutes ready and see if there's any more questions that we'd like to trickle through.
Are there any of the delegates with experience using cones that they want to feed back to us, good or bad? Because, you know, we're all, certainly the trabecular cone, we're all on the foothills of experience, and I'm comfortable using it, but others may have had only 1 or 2 cases and want to comment on them.
We've had one question which I guess would be aimed more at myself than you, and that would be, do Link run any cadaveric courses for cones? Well, unfortunately, right now we don't do a whole lot of anything. We do webinars because we're not allowed to go near each other. But yes, Link do run cadaveric courses throughout the year, and I can just ask that please contact your local territory managers to discuss this, and we'll keep everyone updated or follow on our social media. And I'm sure if we were to ask Rhidian nicely, that he would be happy to be involved in some events like that moving forward. So.
Yeah, absolutely. And in the past, we've always run visitation centres. So if anybody's interested to see a link hinge going in, a link distal femur, femoral tibial cones, osteotomies, you know, with a bit of warning, we can always arrange that.
Absolutely.
You have to go to Cardiff.
As long as you switch the rain off for us, we'll be quite happy.
We're having a month's worth today, I think. So it's.
Okay, we've had a couple more questions come through here. So, again, I think we've partially covered this, but in the case of re-revision, how easy is it to remove a well-integrated cone? So.
Yeah, so the to talk you through it with the TM cones from Zimmer, it's a brittle metal. So basically, you know, it's not loose. Then it's not loose, and the previous surgeon hasn't cemented in. The trick is to take an osteotome and literally cut down all the way around, so you splinter it into pieces, and then you take out each piece. If you try and take it out whole, you lose an awful lot of bone stock around it. With the trabecular cones, what I'm anticipating is you'll either leave it in and do a cement revision, or because the inner seal will stop cement egress around it, you can use some osteotomes to just loosen around it. I would, if it's going to explant, definitely do a tibial osteotomy to get it in front and below, and then you can generally get things out. It doesn't matter what sort of bone loss you've got and what reconstruction options you have next time. It's not the fatality.
Sorry. Next question here said, I think you said that you don't always use cemented stems with a cone. Is that correct? Would be part 1.
Yeah. So you know, sometimes we do hybrid fixation, where we'll cement through. If you put a cone in, you have to cement zone 2, but you can go uncemented below it. And I've certainly done that with, I've used a cone with another implant manufacturer, for example, where the stems are more, a better pedigree for uncemented fixation, if you like. And if there's minimal bone loss and your stem is purely alignment, then put a cone in, and you can put an cement stem below it, just to give you that alignment. The fixation then is all zone 1, 2. If there's a big uncontained defect, you got a cone-free construction, you've got to make zone 3 work harder. So then I'd be fully cemented all the way through it.
And the follow-on to that question was, if this is the case, which it is, how do you ensure adequate cementation in zone 2 without affecting your zone 3 press fit?
Yeah, look, you're always going to get some that goes below the cone, especially whether you go for a proper press fit stem in zone 3. If you do that, obviously cement won't go through it, but you've then got to partially engage the stem, then put the cement in, then knock it through. If the stem is purely for alignment, then it's less of an issue. A little bit goes below the cone into that zone 2, 3 interface.
In the case of extreme bone loss, would you ever rest the implant on the cone, or would you always have cement between the two?
Oh, that's a good question. I think I showed a couple of cases where my cones aren't exactly aligned to the bone and they're a little bit skewiff, a little angled, and so that does rest on the metal, but there's most of the contact area is cement. If you've got a bit of bone mantle between that and cement, the cone, I don't think it matters that much. Generally, I rested on it, but it's almost never parallel to the tray. There's always a little angle, so there's always a good cement interface as well as a bit of point loading. I don't think it makes a huge difference.
Thank you.
So I don't think it makes any you don't get any metal wear and debris in there, as long as you've got good stem fixation through the cone below it.
For sure. I think we've covered this question in the last point, but when you're using a cementless stem, are you looking for a solid press fit or a soft fit? But like you said, if it's alignment, then...
Yeah, so contained defect, then stem can be just alignment. Uncontained defect, stem has to work harder. So do cement all the way through, basically, or put a bigger press fit stem below it.
Okay, if there's any final questions, then I'll ask you to please type them in. But certainly, thus far, I'll take this opportunity whilst we're giving everyone a couple of minutes, Rhidian, just to say thank you as always for your time today. It's always great to listen to your lectures and give us a chance to, learn something from you and ask some questions.
Yeah, I think you have to realise that everything I've learned has been from my own mistakes. So, so the other guys hope you don't make the same mistakes I've made over 20 odd years doing this game.
Great. I'm getting many thank yous coming through. So again, I think I'm going to presume that we've reached the end of the questions for now. So yes, just many thanks again. For anyone that hasn't yet downloaded it, there is a handout available on the right hand side of your screen. There will be a small survey that will come out in a follow-up email just to get some feedback. So please feel free to give us any feedback on these sessions. And if we have no more questions for now, then I shall thank you one final time and hope everybody has a pleasant rest of their day/evening, and we look forward to catching up again soon.
Thanks, Sean. Thanks everybody for listening. Stay safe.
Thanks very much for your time. Thanks now. Bye-bye.